We come on to our next speaker. I am very pleased to introduce Dr. Ivan Martinov, who's going to talk about recanalization through collaterals.
Hello. I'm very pleased to be in this prominent panel. I'll certainly go down below of this theme. This is our vision and techniques in transcollateral and recanalization of peripheral occlusions. I work in the hospital with very much clouds above, a lot of heavy patients. Heavy patients with a lot of comorbidities. We have departments of vascular surgery on site, septic surgery with very heavy patients with amputations and ulcers. And we, for 12 years, we are working with them with more than 3,000 peripheral procedures, along with our cardiology studies and interventions. Most of them are peripheral, and 2/3 of them are fem-pop interventions, and antegrade, retrograde techniques are around 50% of them. Mostly fem-pop interventions, but I think it's a very reasonable percentage in accordance to the success rate of antegrade only. And when you add 50%, it's around 90–95% success rate, which is very good, especially for heavy patients with critical limb ischemia, threatening limb ischemia. We adopted this algorithm for treatment of chronic total occlusions. It's a very popular classification. We working on this decision-making classification. Decision-making is here, and you see that from type 2 to type 4, we are always prepared for retrograde approach to raise the success rate. Only this is the working scheme of this algorithm. You see important things, escalation of techniques, changing between techniques, and very important is not to exceed 3 hours and dosage of contrast. We should think not only for our glory, but for the patient. That's why it's very important to stop if you cannot perform, especially in chronic patients with claudication. We have modification of this technique. We're trying to avoid externalization of the wire, because when you struggle with stenosis, the guide wire is compromised, and sometimes externalization of the wire is very difficult. That's why we are working on this technique. It's not so original, but we adopted almost 100%. You see, we are using rendezvous technique. We are meeting the going down catheter with the guide wire and catheter from below, and in the very tight space it's not so difficult to enter the 4 French support catheter from above, and then push and pull technique. We are trying to stack the wires from above and below together, and we can push from above and pull from below, and when we pass the occlusion we are performing antegrade technique, which is introduced in the scheme before. Because the theme is transcollateral recanalization, it's very rare in our practice too. You should be on an antegrade access because of the sufficient length of the devices. Because when you are contralateral, in femoral contralateral, sorry, Dr. Stankov, sometimes we use femoral, but the contralateral is not good. You should have some experience in, especially in coronary intervention. Unsuccessful antegrade and retrograde attempt. One feeding vessel from, especially for BTK intervention, especially when you there's a problem with the foot, and obstacles like bandages, scars, and so on. You cannot perform retrograde puncture. In that cases, it's good to see the good collaterals and try this technique. This is SFA, which is very rare in our center. You see in the first picture unsuccessful antegrade pass from above, then very good collateral from profunda femoris, and with coronary guide wire 014, we not so easy, but managed to pass through and perform cart technique. We always try to have to manage to pass the wire from above with the cart technique, and not to use larger than 6 French sheets, because in this technique you should have 7, rarely 8 French to do simultaneous ballooning, but in this case it's successful. This is BTK case, which is more often we use transcollateral. You see the diffuse diseased SFA, and one artery to the foot, which is peroneal, with no direct connection to the foot, to the loop, and that's why. And the patient is clinical with CLTI. That's why we need to recanalize at least one of 2 arteries which are providing the blood flow to the foot, direct flow. Our strategy is always try antegrade. Sometimes we use retrograde puncture and techniques. We use mostly the plantar loop for retrograde approach, but sometimes we use anatomical connections. You see in the scheme. These are examples. You see from to the posterior, and according to the small size of the sheet, which is 5 French, we use the retrograde guide wire as a marker where to go with the antegrade wire. In some cases, this is a large collateral, which is not anatomical but collateral. We can subintimal track from posterior to from below to above with the O14 wire. In successful previous procedure. This procedure is again unsuccessful antegrade attempt, and through collateral disconnection between peroneal and posterior artery, we managed to go up with the O14 wire. And our technique, which I showed you before in the FEMPOP interventions, but here O18 catheter with O14 wire. It's a little bit difficult procedure, but successful in this case. And again, we saved 5 French access antegrade, not widening the sheet, and managed to go down with the antegrade catheter, and with some difficulties on the left plane, we managed to go to the plantar artery, and then we succeeded with multiple balloon inflations, and you see the good, almost perfect result. You see the pre and post interventions. Intervention here, but we have not so. And these are new modalities which are in development to see the improvement of the blood flow, but they are in development now. That's why, especially for CLTI patient, it's a must revascularization. That's why we should insist and try to open all the vessel, especially like in this case, which are going to the foot directly, anterior or posterior. Hello. And this collateral technique is one of the options to be close to the 100% success. Thank you for your attention.
Do you also take sometimes the foot arteries to go retrograde up to the lower limb arteries? Because I punctured from time to time the posterior.
Yeah. Sometimes
so that is easy to puncture that?
It's easy, but in some situations, as I mentioned, the scars, the bandages, because these patients are coming from the septic surgery after some amputation or necrectomy, and sometimes it's impossible to reach the posterior or dorsalis pedis or anterior distal part. That's why it's a feasible technique.
Yes, congratulations. Was really convincing, and I think most of the audience will agree with me that the next patient with these problems use the access via collateral arteries. Thank you so much.
Thank you. Thank you.
Thank you very much.